in the young patient with erectile dysfunction and pelvic arteriosclerosis. So the first about the anatomy of the pelvic arteries. I think the first step to enter in this field is to realize the anatomy, but how to realize the pelvic CT angiography will help you a lot. But if you cannot obtain such a good quality pelvic CT angiography, you can obtain that through invasive angiography, but you should realize the anatomy here. And we basically separate that into 8 zones, 8 segments. The first is the common iliac artery, and then the internal iliac artery. If you take an AP view, that's go in the medial part rather than the lateral part. So the first is the common iliac. We call it zone 1, and then it's the internal iliac. And then there's an anterior division. It's better to realize it on the lateral projection, but I will introduce you in the next slide. But you just look at here, that's the anterior division. And the other, that's the superior gluteal artery. It will supply the upper part of the buttock. So the patient, if got a lesion here, the patient will feel claudication. It's called the buttock claudication. And that's the anterior division of the internal iliac, and then that's the internal pudendal artery. Basically, it gives off 2 branches. The medial part is the internal pudendal artery, and the outer lateral part is the inferior gluteal artery. That supplies the inferior part of the buttock, and also the gluteal, and also the sciatic nerve. So some patient got sciatica or a numbness of lower extremity. That's due to ischemia of the inferior gluteal artery. So that's the internal, and then the middle part is the internal pudendal artery. We call it the proximal part and the distal part. The distal part goes along the pelvic floor, and then it gives off the penile artery. We call it dorsal penile, and also there's basically 3 branches. The upper part is the penile artery, and then the bulbourethral, and then the scrotal artery. So that's the brief introduction about the pelvic artery anatomy. And here's the lateral view. I think it's more easy to comprehend. So that's the common iliac, and it's go backwards. That's the internal iliac. We usually go to do the lower extremity intervention for the superficial femoral artery. We go this way to the external iliac, and this is the internal iliac, and you can see very clearly the anterior division and the posterior division. Posterior division means the superior gluteal. So we focus on this: the internal iliac, the anterior division of the internal iliac, and then the internal pudendal artery. So let's go downwards and backwards. That's the proximal internal pudendal and the distal internal pudendal, and then the penile artery. You can see, okay, you can see the mouse very clearly. And that's the dorsal penile artery, and then the cavernosa and the excuse me, this is the common penile artery, and then the cavernosa and the dorsal penile. And we know that the erectile dysfunction, the artery, the real artery that made the erection is the cavernosa artery. That's the artery being measured by the Doppler scan. But actually, the lesion was usually located in this part, in the pelvic floor, in the distal internal pudendal, and the dorsal penile artery. 2/3 of the lesion are usually located here. And the size of the vessel, you can see from 1 centimeter in diameter for the common iliac, and all the way down to around 1.5 in the dorsal penile artery. So based on our the current up-to-date intervention technique and the instruments, devices, we can easily perform angioplasty for all the pelvic arteries in all the pelvic arteries. So that's the pelvic artery. And then basically, even though I named it for erectile dysfunction, actually you can treat 3 kinds of diseases, and there are 3 systems. The first for erectile dysfunction is all the way from the common iliac and all the way down to the dorsal penile artery and cavernosa artery. That's in the red color here. And the other, because the bladder, urinary bladder, is also supplied by the arteries derived from the internal pudendal artery. So if the patient got urgency or overactive bladder symptoms, generally be referred as the lower unit tract symptoms in the urology field. The iliac pudendovascular artery, basically the vascular artery, gives off from the proximal internal pudendal, we can manage that. And then finally, if the patient got a sciatica symptoms or some numbness of the lower extremity, part of them, maybe less than 10%, is due to the lesion in the inferior gluteal artery. So the purple color here, that's from the common iliac, internal iliac, and the inferior gluteal artery. So that there are three arterial systems related to three different kinds of symptoms. Sometimes the symptoms are may coexist, and so that give you a hint about whether the patient is their symptoms are due to vascular causes or otherwise. And the next step, maybe you should arrange either a pelvic CT angiography or some other studies, or maybe even invasive, if you want to try this field. So that's the pelvic artery anatomy I will introduce you. And then here are our results. We named it because it's a quite interesting field. So I personally collected all the cases, and we created a name called a perfect series. It's the acronym of the pelvic revascularization for arteriogenic erectile dysfunction. Up to now, we screened more than 1,400 patients by pelvic CT angiography. We performed more than 530 cases of invasive angiography for these cases, and around 400 cases for the angioplasty. We summarized this into different trials, some being published, some being reported in the international conferences. But I will show you the result in the next slide. Basically, this is the around 180 patients being followed by pelvic CT angiography at 8 months, and the results here. The average age is about 60. The erectile dysfunction being evaluated by the IEF-5 score. That's a questionnaire, internationally recognized or validated questionnaire. In general, there are moderate erectile dysfunction. The period of erectile dysfunction is in average about 3 years, and a total of 334 lesions being treated and being followed. And you can see here, if you look at here, probably around 200 or more lesions are located in the distal internal pudendal and the penial artery. That's what I said in the pelvic floor. So 2/3 of lesion over there. And the risk node rate, there are huge difference according to the location of the lesions. For lesions in the proximal internal pudendal artery and above, the risk node rate is only about single digits, less than 5%. So that's a kind of the experience we get from the coronary intervention. But for lesions in the distal internal pudendal and the penial artery, the risk node rate is quite high. It's about 30 to 50%. Drug-coated balloon performed best is about 30%. But we are trying some different approaches to make the results better, because the risk nodes do influence a lot. The clinical response for any improvement, the patient, about 3 in 4 patients got some improvement during the follow-up periods. But after 1 year, the sustained improvement being achieved by around 60%. The major determinant for the success or failure of this treatment to improve erectile dysfunction is whether the lesion got any binary restenosis. Because in general, you can see here a total of 334 lesions for 180 patients. So in average, about 2 lesions per patient. So if any lesion got restenosis, the result will become much worse. And you can see if there's no lesion at 8 months, the response rate approaching 80%, and any response is approaching 90%. But in contrast, if one restenosis occurred, the response rate is down to 33% at 12 months. So that's a huge difference. So what kind of lesion should be treated? The cutoff point for the stenosis and what should be based on. I think personally, at the present time, the diameter stenosis of more than 50% is the cut point, because we notice that for restenotic lesions, the average diameter stenosis is about 50 or more. And then being criticized a lot is whether you got physiological evidence for any improvement or somewhat. So probably 3 years ago, we started routinely perform penile Doppler scan for this before the intervention. And then you will find interesting finding because usually, well, not usually, but sometimes the Doppler finding and CT finding, are not consistent. So there are 4 scenarios. If that's consistent, it's very easy. But if that's not consistent, and I think the inconsistency happen in around 30 to 40% of cases. So if there's no lesion in CT angiography, but there's a positive Doppler finding, you have to search for some small vessels or accessory vessels because some small vessels cannot be visualized in CT angiography. But if you've got a CT angiography definite stenosis, but there's no problem in Doppler, and the question is, what is the definition of problem for Doppler scan? It's still controversial, but if there's contradicting finding, positive CT, so the current strategy is if there's no lesion on the other side, if there's a lesion on the other side, we treat the other side. And if there's no lesion on the other side, and there's only one side lesion, the Doppler is good, but we still